morning. I'd like to call the meeting of the Minnesota Senate Health and Human Services Finance and Policy Committee to order. It is Tuesday, March 11th, and we do have a quorum present. Our first bill on the agenda is Senate File 1622. Senator Mann.
Thank you, Madam Chair. I do have the A1 very technical amendment.
Senator Mann moves the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Senator Mann.
Thank you, Madam Chair. So federally qualified health centers, or FQHCs, are safety net clinics located across the state, and they are reimbursed using a different model than traditional Medicaid. They instead are reimbursed through an encounter rate based on cost reporting. Currently, health centers have these rates rebased every 2 years from cost reports from 3 to 4 years prior, and can only have these rates adjusted when there is a change in services amounting in a 2.5% increase or decrease in total services. This creates a lag in reimbursement that has not been able to keep up with the changing face of healthcare. Health centers report increased difficulty in keeping up with workforce changes and the ability to expand in needed services. So this bill does two things. One, it adjusts cost reporting structure from reports that 3 to 4 years prior to 1 to 2 years prior, which obviously allows for a more accurate reflection in operational costs. And two, it adds language to allow health centers to have their rate reviewed when there is a change in time intensity, duration, or amount of services. So this would allow for health centers to more quickly adopt changes like the collaborative care model, expand maternal health services, or otherwise respond to the complex needs of high acuity patients that they serve. Health centers otherwise lack the flexibility to innovate and meet their patients and communities where they are. With that, Madam Chair, we do have some testifiers.
Thank you. And I see Lee Holman and Becky Howard, and if you could state your name for the record and then begin your testimony.
Okay. Lee Holman, I'm the Chief Executive Officer for Lake Superior Community Health Center. Good morning, Chair Wiklund, ladies and gentlemen of the committee. My name is Lee Holman. I'm the CEO for Lake Superior Community Health Center in Duluth, Minnesota. First, I'd like to thank Senator Mann for carrying this bill and for her strong support of community health centers and the people and communities we serve. I'm here today on behalf of the Minnesota Association of Community Health Centers to voice strong support for SF 1622. As Senator Mann said, this bill accomplishes two things. First, it adjusts the cost data used to set our payment rates from 3 to 4 years prior to 1 to 2 years prior. This allows for more accurate reimbursement rates that are reflective of our actual costs. Using cost reports from 1 to 2 years prior will align more closely with recent operational costs rather than using the current methodology that consistently fails to fully and promptly incorporate increased costs associated with current market conditions and patient complexity. We've seen a significant increase in costs due to inflation, upward pressure on wages due to workforce shortages, and increased patient complexity, making older data less reflective of our current work and the costs we incur. Second, this bill adds language to allow health centers to have their rate reviewed when there's a change in time, intensity, duration, or amount of services we provide. This specific language was borrowed from Washington State. However, it is also a tool I have available as a health center with locations in Wisconsin, where a rate review is allowed when there's a change in intensity of services. For example, every FQHC has experienced increasingly complex patients in recent years. Most of our patients are navigating multiple chronic conditions, many have behavioral health needs, and some are facing challenges with substance use. To effectively meet the needs of these patients, a health center should feasibly employ additional therapists to avoid wait lists, a dietitian to help navigate diabetes and other chronic conditions, and an increase in expenses associated with chronic disease management and substance use services. Under the current Minnesota statute, our rate would not reflect these increased costs for up to 5 years. In the same scenario in Wisconsin, we have an opportunity to begin the change in scope process in year 1. In Minnesota, the rigid statute allows review only when there's a 2.5% change in our encounter rate, and that limits my ability to respond to new and emerging patient needs, something that's central to our mission and our mandate as a health center. Effectively, it forces a health center to bear the financial burden of expanded services for up to 5 years while we wait for these services to be built into our Medicare cost reports and subsequently reflected in our rebasing for the 2 years following. Health centers operate on extremely tight margins. We pride ourselves on our ability to stretch the dollar, and for over 60 years we've enjoyed bipartisan support because we're recognized as a cost-effective mechanism for healthcare delivery for our community's uninsured and underserved populations. In fact, health centers serve 6% of the Medicaid population in the state on 1.2% of the budget. Without the flexibility we are suggesting here, many health centers do not have the financial means to bear that cost, which means services are not expanded and folks go without care they need. We understand DHS has some questions about the language to ensure accuracy, and we are fully committed to working with the department to make sure we get the language right, but we also know that this is a critical tool in our toolbox that could support health centers as we continue to provide needed care across the state. Thank you for your time and your attention to this matter.
Thank you very much for your testimony. Ms. Howard, please state your name for the record and begin.
Becky Howard. Good morning, Chair Wiklund and members of the committee, and thank you, Senator Mann, for carrying this bill forward and for your support of health centers. My name is Becky Howard. I'm the Acting Chief Operations Officer of Community Health Services, Inc. in Rochester, Wilmer, and Moorhead, Minnesota. We serve patients across the western part of the state who may not otherwise have access to primary health services. And I'm here today to express support for Senate File 1622, which allows for health centers to have their rates reviewed when there's a change in duration, intensity, and amount of services. For CHSI, this would mean the ability to expand, for example, prenatal services and obstetrical services within our FQHC in Rochester. Our patients already face barriers to timely prenatal care, including financial constraints, lack of transportation, closures of other rural clinics, and limited access to specialty providers. By adding prenatal and obstetrical services, we can directly address a growing need in our community. With the addition of these services, while the addition of these services would not immediately translate to that change in our total revenue of 2.5%, it would significantly increase the intensity, duration, and amount of care we provide to our growing patient population. The addition of comprehensive prenatal and obstetrical care will require specialized OB/GYN providers, certified nurse midwives, and partnerships with maternal fetal medicine specialists to manage both routine and high-risk pregnancies. This change will increase patient encounters, requiring additional exam rooms, ultrasound capabilities, lab services, and 24/7 on-call support for obstetric emergencies. This is a challenge at CHSI we would love to take on. However, we do not have the funding to carry the financial burden of this change for 3 to 4 years as we wait for these services to be built into our rates through the current path of cost reporting and rate rebasing. So this is just one example. Another health center may choose to build out dental, another behavioral health or substance use disorder services, or participate in a collaborative care model that this committee heard the week before last, or to simply continue operations as they are. This bill is about flexibility and allowing health centers to be nimble in the changing landscape of healthcare. But again, for us, with this bill, Minnesota has an opportunity to significantly improve maternal and infant health outcomes, particularly for low-income populations in Rochester. We stand ready to meet this urgent need, but we require state support to ensure this expansion is financially and operationally sustainable. Thank you so much. I'm available for any questions you might have.
Thank you. That's all the testifiers I have. Members, do you have any questions or comments about the bill? Senator Abler.
Thank you. Senator Mann, thanks for taking on this topic. The FQHCs do remarkable work in very challenging populations, and you know, it's good to take a run at this version. I've tried to help get funding. There was funding that was kind of set up, and it didn't seem quite right, so they chatted, and then there was a law that we passed, and then a lawsuit, and then a law. So anyway, someday it's going to be sorted out. I don't understand the resistance to getting this sorted out to the veterans of this whole thing. So, but for sure, if you add a whole new package, that should be worth something. So I cheer you on in the negotiations. And I want to remind people that the population served here are some of the most challenging ones that this committee is charged with dealing with. There's not a lot of commercial insurance in their world. There's not a lot of parallel services available. And so, Senator Mann, thank you, and to the testifiers and to the people that serve. I admire their work, and hopefully this is it. Thank you.
Any other members, questions or comments? Senator Mann? Well, I appreciate your bringing this forward. I agree with Senator Abler that this type of service is just so essential, and also we need to find ways to react more quickly to changing needs, especially when serving. If you find a model or something that works, then being able to change and adapt in a more timely way, it seems really essential. So I appreciate your coming to testify, and Senate File 1622 as amended will be laid over for possible inclusion. Thank you. And next we have Senator Mann, Senate File 1785. And I just wanted to make a note, Senator Port is online today, so just for the record. So, Senator Mann.
Thank you, Madam Chair. So 1785 continues to build on Minnesota's medication repository program, where unused medications are donated and distributed to people who need them. What we have seen since our repository program launched is an explosion of need. And so the incredible pharmacists that run our program started looking at what other states are doing to meet this need and this demand, and Senate File 1785 follows in the footsteps of many of those states. The big pieces in this bill are that it includes base funding to keep the program up and running, and it starts a purchasing program to fill in the holes. So for example, if someone needs a 10-day prescription for an antibiotic, but we only have 7 days, it will purchase another 3 days. That's it, Madam Chair. With that, we do have testifiers.
Thank you. And I have Rachel Rockwell. And if you can please state your name for the record and begin your test.
Hi, my name is Rachel Rockwell. I'm the Managing Director and Pharmacist in charge at Roundtable RX. And our mission at Roundtable RX is to offer safe and affordable medications to Minnesotans in need, provide continuity of care, and reduce waste by redistributing unused medications. We receive donations of medicine that are sealed and in tamper-evident packaging and are unexpired. Before medication reaches the patient, it is thoroughly inspected by a licensed pharmacist, and our top priority is safety. Of note, we do not accept controlled substances in this program. Since receiving state funding in July of 2023, our program experienced remarkable growth. We have seen a 300% increase in the number of medications redistributed since receiving funding from the state in July of 2023, a direct reflection of the increasing demand for the program for Minnesotans in need. Receiving state funding has better aligned our state's program with other states operating similar programs, including that in Iowa as well as Wyoming. The most impactful repository programs are largely state funded. State funding for fiscal years 2023 and 2024 provided a financial stability needed to meet growing demand and expand operations, including a significant increase in medication donations received, a corresponding increase in the volume and value of medications redistributed to Minnesotans in need, and the establishment of a dispensing pharmacy set to open this year, which will expand our reach by delivering medications statewide via mail while further reducing medication waste. With this rapid growth comes the need for additional and ongoing funding. Continued support will allow us to keep pace with demand through our wholesale operations, open and staff the dispensing pharmacy to ensure that no Minnesotan is left without their essential medications, and further increase our impact by ensuring donated medications reach those in need as efficiently as possible. A third-party research firm recently conducted an independent impact analysis of our program. Their finding indicated that our reported medication value is likely underestimated by 60%. This is because our reporting is based on NADAC, which is roughly the price a pharmacy would pay for the medications we redistribute, rather than the significantly higher out-of-pocket that patients face at the pharmacy counter. At the time of the study, Roundtable RX reported the value of medications dispensed or distributed at about $640,000, while the impact analysis estimated the value at closer to $1.8 million in value of medications distributed. Furthermore, the researchers estimated the true value of our impact at nearly $2.8 million since opening in 2020. This value accounts for healthcare system savings from avoided hospitalizations, improved patient health, and overall societal benefits such as increased workforce participation and reduced financial stress. To help put this into perspective, here's a recent testimonial that we received from a Roundtable RX patient. I quote, "Before Roundtable RX, I was unable to take my medications for several months," said the patient. I quote, "I am finally able to get back on my medications without having to worry about my bill and food budget being affected." Included in this bill are two key policy changes requested by Minnesota Board of Pharmacy staff. The first is to Subdivision 6. This change would permit the Roundtable RX pharmacy to purchase medications from a wholesaler when there's not sufficient donated stock to fill a prescription. However, donated medications must be prioritized and used whenever possible. This is common practice for other states where the repository program operates a dispensing pharmacy, including Iowa and Wyoming. And then a change to Subdivision 10 is also being requested. Presently, statutes indicate a local repository can destroy repository medications in cases of recall, but it is not clear that they can destroy them if the product is damaged in transit or expires. This change clarifies that local repositories may destroy repository medication not suitable to dispense to a patient. These changes will improve access to our program while further reducing medication waste. This is a cost-effective solution to healthcare inefficiencies. We are taking high-quality medications that have already been paid for and would otherwise be destroyed, and providing them to Minnesotans who might otherwise go without. Investing in this program reduces the burden on hospitals and taxpayer-funded healthcare programs by keeping people healthier and out of emergency rooms. This is a fiscally responsible approach. By supporting Roundtable RX, you are ensuring that Minnesotans can access the medications they need, reducing pharmaceutical waste and saving taxpayer dollars. This is an investment in people. When Minnesotans can afford their medication, they stay healthier, remain in the workforce, and contribute to their communities. The proposed legislative changes and additional funding will allow us to meet the increase in demand for our services while ensuring the program's long-term success. We urge you to support this bill to improve access to life-saving medications, reduce waste, and protect the health and financial well-being of patients. And I just want to end with one more patient testimonial, because testimonials from patients are what we're here. We're here to serve the patients. So a patient with congestive heart failure suddenly found themselves without insurance. Their condition required them to take 2 very expensive brand name medications. Without insurance coverage, they were forced to go without until their provider recommended Roundtable RX. I quote from the patient, "Thank you to my care team and Roundtable RX. I'm able to have meds I would have otherwise gone without. Thank you from a congestive heart failure patient who would die without these pills." End quote. Thank you for your time and consideration, and I'm happy to answer any questions.
Thank you. And did you wish to testify as well? If you could state your name for the record if you...
I'm Dr. Rowan Mann. I am one of the original founders, and I was just here to answer any historical questions if they came up.
Okay, thank you. Members, do you have any questions or comments? Senator Abler.
Not to disappoint, Madam Chair. This is really an interesting story. Maybe it was kind of mentioned, but I think you were a student at the time, and they said, "Hey, we're throwing away all these meds at nursing homes, and can't we reclaim them?" And with no lobbyists and just with their own chutzpah and really good ideas, a bunch of us thought this was a great idea, and here it is now evolving into a whole thing. So. There is a place for citizens in the legislature. Sorry, lobbyists. Anyway, so we need you too, of course. So I just have a question, a couple of questions. So on the funding part, this was one-time funding in 24 and 25, is that right? And then there's nothing in the tails, is that right?
That is correct. There was only funding for fiscal years
Ms.
2023
Rockwell.
and 2024, and so we're asking for base funding.
Right, Madam Chair.
Senator Abler.
You know, I don't know, just to remind people, I cautioned about one-time funding for base programs, and this is an example. So what happens, I don't know if you've noticed, we're a little light on money these days. I think $6 billion is a lot, but that's just me. But anyway, so if you don't get, if the funding drops to zero, what happens to your program?
Ms. Rockwell?
Sorry, Madam Chair, thank you. We would essentially dissolve. We have some additional funding, but not sufficient to support the full operation and administration of the program.
Yeah.
Senator Abler.
All right, I just would hate to, you know, and you're hoping to expand, and I don't, maybe I'll be in some of those meetings where we decide what we're going to buy, but it would be nice if this thing could be allowed to continue. I think it's really useful, and I suppose maybe you could reconfigure it to be a little lesser of a thing. You could still reuse drugs somehow, but you don't have a mechanism without the base funding to do that. Is that right? I'll make it a question. So,
Ms. Rockwell.
That is correct.
all right. Well, thank you, Madam Chair.
Any other questions or comments? I guess I have a question. I wondered, given, the discussion about the funding is timely. We will have to look at all of the things that are before us and figure out if we have availability for an appropriation like this. It does seem like a very worthwhile program. Would the policy or the language changes that are in the bill be something that you would desire to see happen, even if the funding is different or, altered? Ms. Rockwell?
Yes, we would still like to see the policy changes.
Okay. And then in terms of the amount, it looks like the first allocations or first appropriations were a little less. Is that, I know you've determined that you believe that the base funding of, $900,000 a year is what you'd seek, but would something closer to what you originally received, is that still enable you to continue? Or I don't know if you have any comment about scaling the funding. Ms. Rockwell?
It would allow us to continue wholesale operations, but it would not allow us to open the dispensing pharmacy, which would then leave substantial gaps in our delivery to all Minnesotans. Because right now it's only accessible with the wholesale operation, only accessible to those that have a partnering clinic or pharmacy within their neighborhood. And we know that especially independent pharmacies, which are some of our largest partners, are closing like crazy in Minnesota. And so it really would cause a significant, or continue to cause a significant disparity in access to the program, particularly for greater Minnesota residents as well as rural residents.
Thank you. Yeah, that's helpful to know. Senator Mann, did you have comments?
Madam Chair, we have a program that reduces clinic visits, ER visits, hospital visits, keeps food on the table. I think it's a really spectacular program and reduces waste on top of that. If we can do something like this, as well as help our pharmacies stay open across Minnesota, we have a real chance here to do something big in our state. So I hope that we consider this along with our other programs this year.
Thank you. Yeah, it does seem very worthwhile, and a lot has been accomplished in just a few years. So Senate File 1785 will be laid over for possible inclusion. Thank you. And next we have Senate File 333, Senator Dahms. Welcome to the committee, Senator Dahms, and when you're ready, please begin.
Well, thank you, Madam Chair and members, for considering Senate File number 333. Senate File Number 333 is the reinsurance bill, which we put into play in 2018. And in order to do that, we had to get a waiver from the federal department, and we were able to get that waiver. And at that point in time, the waiver consisted of two pieces. There was one part of it that was, both of them had money, dollars tied to it. The first 5 years, we were unable to get the second part of the waiver. When we renewed this waiver back in 2023, I believe it was, we did get the second part. So what that amounts to is we have about $130 million that comes from the federal. Roughly 100 part of that is for the first part of the waiver, and then the second part is about 30 million. So what Senate File 333 does is we've already applied for the waiver, and the waiver was given for 5 years as is usual. And so we're going through the third year this year, so we have 2 years left of the waiver. So mostly what this bill does is it does secure the funding for the final 2 years. Also, it talks about changing, we made a change in Section 3. Instead of having 23 to 27 listed, we struck that out, and it says for all benefit years which federal authorization for the reinsurance program is received. And then on Section 3, it's that language deals to continuation of the waiver, and that language talks about giving the department, asking the Department of Commerce to apply for the waivers in prior enough time to make sure that the waivers get in place and stuff before the old waiver runs out. So that's really the three parts of the bill. And then, of course, the fourth, Section 4, I should say 4 parts of the bill. Section 4 is where it's requesting funding, and it's requesting $512 million to be put into the premium security account, and that would take care of the next 2 years, which would be year 26 and year 27. Several questions come up as this bill passes through the various committees. There's always a lot of good questions. And one of the questions that comes up is how are we going to pay for this? And if we take a look right now, in the healthcare, in the premium security account, there is $284 million that legislatively was asked to be taken out in 2023 or 2023, and then another $8 million is to be taken out in 2025. That money has not been transferred at this point, and so that money, $284,000 roughly, is sitting in that account that's been looked at being taken out. If we leave that money in that account, which I would highly suggest and ask that we do that, then that would mean we'd need about $228 million out of the general fund. Now, in the past, when we look at how we funded this bill, we've used different options. One of the options we've used every time is the money from the federal waiver. Now, this year, we're using in the projection $130 million for the federal waiver, and that's been the same now for the last, I believe it's 3 years. So what we're finding is when we do the price, when we start pricing this program, we're holding the amount we're going to get from the waivers at a flat amount, but we're increasing the usage and the cost. We're increasing the cost of the program by about 12% per year. And so when we take a look, and this is how it's been done ever since day one when we put the program into place. And so I think part of the reason for this is because we want to make sure that the funding is there to provide what we've told the people we would provide. So we do end up with these fund balances. Now, in the past committee, it was talked about the fund balance and how that money should be taken out. Well, when the money, and the comment was made that this wasn't for reinsurance. Well, when you put money into the premium security account, it's for reinsurance, or you wouldn't be putting it into the account. So my thoughts on this is that when we took that, requested to take out that $284 million, what happens is what's happened in the past. We end up with some surpluses in the account because of the way that we look at. We usually look at the maximum cost increase and hold back the amount we're going to get for the waivers. So that's part of the reason we have a pretty good surplus in the account, is because of that fact. Now, Granted, when we originally started this, we did not take into account we'd get the second part of the waiver, which is about $30 million. So if you take that $30 million and multiply it out, and take that out of the account, we still would have a considerable amount of money left into that account. So my comments would be is that as far as funding it, in the past, we've taken money out. We've always used the federal waiver. We've taken some money out of the Healthcare Access Fund. We've taken some money out at sometimes through the Premium Security Account. And what we see is that sometimes we've used a combination. Sometimes we've taken some from the general, accepted the federal government's waiver money, and then also taken some from the Healthcare Access Fund. Other times we've taken more of it out of the general fund. So with that said, Madam Chair, we do have some testifiers. So if you would like to go ahead with the testifiers, I would appreciate it.
Thank you. Mr. Andreessen, please state your name for the record and begin your testimony.
Madam Chair, members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans, representing nonprofit insurers in the state. Thank you for the opportunity to testify today in support of Senate File 333. Minnesota's reinsurance program has been a resounding success in stabilizing the individual market and reducing premiums on average by 20% through a funding partnership with the federal government. Since the start of the program, Minnesota has been ranked number 1 or 2 for the lowest premiums in the country, according to the Kaiser Family Foundation's list of state premiums, or average premiums by state. The advantage of the program is that its benefits are invisible to someone who enrolls in an insurance product. No one needs to apply for a special program, and everyone buying an insurance product receives the benefit. The state uses an attachment point model, meaning the program only pays 80% of enrollee claims between $50,000 and $250,000. All claims above and below this threshold are paid entirely by a health plan. Health plans submit claims to the state, and once federal matching funds are received, the state makes payments to health plans 12 to 18 months after the health plan had paid the claim to the provider. Even though the payment is retrospective, since health plans know the subsidy is coming, they're able to account for this in their rates and lower premiums. Now, we're going to hear a lot of misinformation about this program and assertions that this is a bailout for insurance companies. This is a subsidy for patients and keeps money in the pockets of your constituents that they otherwise be paying in premiums. Reinsurance money is being used to pay the endocrinologist who is treating somebody with cancer, with diabetes, an oncologist treating somebody living with cancer, or a cardiologist treating somebody with a heart condition. 100% of reinsurance funds are being used to pay medical claims for chronic conditions, and nothing is kept by health plans for administrative costs. Reinsurance payments are subsidized or summarized in quarterly and annual reports performed by an independent actuarial firm, and all these are posted online. This alone is the number of reports that was done for the 2023 plan year. Reinsurance is one of the most audited programs in the state, and everything you would need to know is in these reports. These reports show how much is spent and how it is being spent. This includes breakdowns on reinsurance payments by health plan and their products. You will see in the report in your packets that only nonprofit insurers are receiving reinsurance payments. No for-profit insurer is receiving reinsurance payments. The report also breaks down payments by metal level, plan type, exchange status, claim spend, geographic area, and which chronic conditions are being subsidized. High medical costs for over 4,200 patients were subsidized in 2023, including people living with diabetes, asthma, heart conditions, rheumatoid arthritis, cancer, and more. Now, as for funding, the state has historically contributed general fund and healthcare access fund dollars to this program to leverage federal funds. Both the healthcare access fund and general fund are supported by a broad set of taxes on many entities, including health insurers who contribute over $600 million annually to the state budget. In addition, health plans pay an assessment to help fund MNsure and hold on to $1 billion of payment delays in the Medicaid program to stabilize the state budget. Health plans are already helping to pay for the reinsurance program by paying into the state budget, which is the source of program funding. Now, if you wanted to ensure health plan taxes are being used for reinsurance, you could direct any or all these taxes to the premium security account. We recognize the level of funding is being requested is significant, but the return on investment is also significant. The investment benefits Minnesotans who are in the market and have no other options for insurance. For most, it's either buying insurance or going uninsured. The council thanks Senator Dahms for his leadership and asks for your support. Thank you.
Thank you. Mr. Graves, please state your name for the record and begin your testimony.
Thank you, Madam Chair and members. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce. We support continuation of the state's individual market reinsurance program because it's brought stability to the individual market. For context, we should look back to September 30th, 2016, when then Commissioner of Commerce Mike Rothman issued a press release announcing the 2017 premiums for the individual market. Here's what the Commissioner said. For the 7 insurers in the individual market, the 2017 rate increases ranged from 50 to 67%. The individual market's largest insurer, covering 103,000 Minnesotans and about 40% of the state's total individual market, was forced to leave the market due to ongoing financial losses. Enrollment caps were instituted to address the concerns of the insurers left in the market, many of whom were also considering preparation or making preparations to exit. As Commissioner Rothman put it in the release, quote, Minnesota's individual market for 2017 was on the verge of collapse, end quote. In explaining the reasons for the turmoil, the Commissioner noted that the rate increases were, at least in part, reflective of a national trend. But he also went on to note the following, quote, Minnesota's individual market also faces unique challenges because of a disproportionate concentration of individuals with serious medical conditions whose high claims costs must be absorbed by a relatively small risk pool, pushing up rates for everyone in the individual market. The Commissioner urged quick action to protect Minnesota consumers who purchase their own health insurance, and in doing so, recounted heartbreaking stories about hardworking families struggling with tough, painful choices because of skyrocketing costs. As you can see, and as some of you may remember, this was a very difficult time in our state. Fortunately, the governor and the legislature in a bipartisan manner took action and established the state's reinsurance program to lower premiums and stabilize the market. It did this by addressing the unique problem identified by then Commissioner Rothman. The program leverages state and federal funds to help pay for the high-cost claims of the sickest individuals in the market, taking these costs out of the calculation of rates and lowering costs for everyone in the individual market. As a result, thanks to reinsurance, in 2025, we have the second lowest individual market premiums in the country in a stable, growing market. The Department of Commerce reports that premiums in the individual market are about 25% lower than they would otherwise be without reinsurance. And we know that rates would increase significantly in 26 and 27 if state funding for the program is not provided this session. We thank Senator Dahms for bringing this bill forward, and we ask the committee to support its passage. With the value of hindsight and the proven track record of our reinsurance program, we can help ensure continued stability in the individual market and help ensure we don't return to those troubling and challenging days in 2016 and 2017. Thank you, Madam Chair, for the opportunity to testify. I appreciate the opportunity.
Thank you. Next, I'd like to call up Ann New-Brindley and Mike Anderson. Welcome to the committee, and please state your name for the record and begin.
Thank you, Madam Chair and members. I'm Ann New-Brindley. I'm the Health Policy Director with the Minnesota Business Partnership. I appreciate having a few minutes to testify in support of House File 333 this morning. So the Minnesota Business Partnership represents business leaders from the state's largest employers, who collectively employ nearly 500,000 workers in Minnesota and 4.8 million globally. Minnesota consistently ranks among the top states for healthcare quality and has one of the lowest uninsured rates in the nation. Our state is also the 4th in the country for employer-sponsored insurance and 6th for employer contributions to the cost of healthcare for their employees. Every Minnesota Business Partnership company offers employer-sponsored healthcare, which might beg the question, why do we care about reinsurance? But affordability, access, and equity in healthcare are key priorities for our members. Reinsurance has been an important piece of the puzzle in stabilizing not just the individual market, but the broader healthcare ecosystem across the state as well. Without its extension, premiums could increase by 25% or more, leaving tens of thousands of Minnesotans without affordable coverage. Such a significant rate hike would not only put coverage out of reach for many, but it would also likely lead to substantial budget shortfalls for healthcare providers and drive up insurance rates in the commercial market. And that creates widespread instability across the healthcare ecosystem. Not only do Minnesota Business Partnership members care about their neighbors and making sure all Minnesotans have affordable coverage, but they also understand that moving almost 100,000 people out of the commercial insurance market leads to more uncompensated care, It leads to higher insurance rates for workers across Minnesota and potential disaster for healthcare providers who are already operating on the margins. And this, of course, possibly results in pretty catastrophic closure of service lines and facilities, and ultimately less access for everyone. I understand that when reinsurance was first passed in 2017, the hope was that it was going to be a temporary program to stabilize the market while a better solution was found. And I appreciate that those conversations continue. The reality is that the program has been really effective in ensuring care for people for whom care is expensive, people with chronic or complex conditions that require consistent care. The Minnesota Business Partnership is committed to supporting affordable, accessible health care for all Minnesotans and a stable healthcare ecosystem, and reinsurance plays a crucial role in achieving those goals. Thank you, Madam Chair.
Thank you. Mr. Anderson, please state your name for the record and begin.
Good morning, Madam Chair, committee members. My name is Mike Anderson, and I'm the past president of the National Association of Benefit and Insurance Professionals of Minnesota, and I'm an independent agent serving individual and employer clients here in the Twin Cities. I'm here today representing the Agents Coalition, which includes 4 professional agent associations in Minnesota, including the National Association of Benefit and Insurance Professionals, National Associations of Insurance and Financial Advisors, the Professional Insurance Agents, and the Big I of Minnesota. Collectively, we represent over 54,000 licensed insurance agents throughout Minnesota. Our agents represent about 2.25 million Minnesotans covered by the private market, and we work closely with both group and individual market consumers on a daily basis. We strongly support the extension of the reinsurance program, and we thank Senator Dahms, Klein, Seeberger, Utke, and Duckworth for their authorship of this bill. The individual marketplace is not only where individuals and their families get coverage when they do not have access to employer-sponsored coverage, it is where entrepreneurs get coverage that enables them to start a new business, and it is also relied upon by individuals between jobs and early retirees. State funding has been a part of supporting high-cost individuals since the MNsure high-risk pool was created in the 1970s. In 2013, $176 million in MNsure claims were covered by taxes to support this high-risk pool. In 2014, the implementation of the Affordable Care Act individual market reforms, about 27,000 high-risk MNsure enrollees, the entire risk pool, entered the relatively small individual market, but without this taxpayer funding. The benefit of this ACA reform was that the high-risk individuals who were previously only given a few choices of plan design in the high-risk pool could now buy any plan in the individual market that fits their needs. Just a few years after the MNsure high-risk pool was ended, the premium impact in the individual market drove huge premium increases, carriers leaving the market, and consumers, our clients and your constituents, were getting headline-making double-digit premium increases. The missing piece of the puzzle was that the tax support should have followed the high-risk individuals into the individual market. Reinsurance filled the gap a few years later, but at a much lower cost than the previous program, clocking in around $139 million in 2018 versus MNsure program at $176 million in 2013. In reality, reinsurance is the continuation of the premium support from taxpayers to the MNsure high-risk pool, which is now part of the individual market. When the reinsurance program was first implemented, according to the Minnesota Department of Commerce, this plan resulted in premiums being 20% lower in 2018 than without reinsurance. All the benefits of this program go directly to the consumers in the form of lower premiums, as shown through the Department of Commerce rate filings of the carriers, which were filed with and without reinsurance due to the timing of the passage of the reinsurance bill. No funding goes to the bottom line of the insurance carriers, since they can only get reimbursed for actual medical bills and are then reimbursed by MNsure within the narrow statutory parameters of this plan. They cannot receive reimbursements for their overhead and administrative costs, only for actual medical expenses. We are pleased that Governor Walz included an extension of the reinsurance in his budget. However, we do have significant concerns about the proposed new MNsure tax, which is a tax that hits small businesses and individuals particularly hard. Instead of adopting this new tax on a narrow base, we encourage you to consider much broader funding sources, including the general fund or the healthcare access fund, that reflect benefits of this program to all Minnesotans. We ask that you renew this program with two principles: provide permanent base funding so that our clients are not subject to uncertainty about the funding every few years, and support a broad-based funding source either from the general fund or the Healthcare Access Fund, and oppose the new MSHA tax, which is just another tax on small businesses and individuals that would be passed through to policyholders and not borne by the insurance carriers. Thank you for your time.
Thank you very much. Next, I have Leota Goodney and Matt Flanders.
Good morning.
Welcome to the committee, and please state your name for the record and begin.
Good morning. My name is Leota Goodney, and I am a retired CPA from Northfield, where I practiced for 39 years, serving individuals and small businesses, most with one or two owners. This allowed me to observe the increasing costs of health care, and particularly the problem of affordable health care premiums to individuals and small businesses. Minnesotans in rural locations like Northfield or urban ones, no matter the composition of their family or their cultural heritage, should have access to quality, affordable health care. Through Minnesota Care and other health programs, the state of Minnesota has made a big difference for many people. In a time when the state budget projections show only a small surplus for this biennium and projected deficits going forward, we must make sure that our tax dollars go to support Minnesota residents rather than profitable healthcare or corporations. Minnesota has spent over $1 billion of taxpayer dollars to support the health insurance industry through insurance since 2018, when the program first came into being. And as the senator said, this file will cost another $512 million in the next biennium. Remember that surely it is time for the health insurance industry to insure themselves rather than through some assessment fee, as is done in many other states. Minnesota is one of the highest cost states for general fund dollars going into this program. Our public dollars should be much better used to reduce medical costs for Minnesotans in other ways, supporting access to health care, such as the two bills we heard earlier today. I'm also concerned that the current federal administration will reduce federal aid for Minnesota Care, as happened in 2018. Small businesses, while I was still working, made extensive use of Minnesota Care during startup, as the gentleman mentioned earlier. And my own child has used Minnesota Care when she had a toddler, a low-paying job, and her partner was suffering severe mental health crisis. Minnesota Care is an important program. Any reinsurance, however funded, must explicitly protect funding for Minnesota Care. While the concern for increased premiums in the private health insurance market is a real one, those premiums will probably increase substantially to unaffordable levels because of actions at the federal level, which we have little control over here. Continuing to put Minnesota tax dollars into reinsurance is not going to change that, and it puts a big dent in our ability to care for each other in a financially prudent way. If there must be a reinsurance program, and you heard many reasons for that, then I encourage you to look to other states to see a better way. Thank you for your attention.
Thank you very much. Mr. Flanders, please state your name for the record and begin.
Good morning, Madam Chair, members of the committee. My name is Matt Flanders, and I'm the Legislative and Policy Director at Citizens Council for Health Freedom, a national nonprofit health policy organization based right here in St. Paul. For over 25 years, our mission has been to protect patient and doctor freedom. I'm here today to share our opposition to Senate File 333, which would continue the Minnesota Reinsurance Program, a program we've opposed since its introduction in 2017. We empathize with Minnesotans who have felt significant increases in the cost of health insurance in recent years. As one who once purchased personal health insurance on the individual market, I also experienced the sticker shock and wished there were better options for me to consider that did not bust the monthly budget. Reinsurance, however, is not the solution. We oppose this bill for three main reasons. First, it does not actually reduce the cost of health insurance and instead uses taxpayer dollars to hide the rising costs from consumers. Second, it erodes patient data privacy. And third, it would establish this reinsurance redistribution system in perpetuity, as long as the innovation waivers are approved. Because the reinsurance program operates in the background, sharing dollars and data outside of the public view, people who purchase health insurance in the individual market will likely not know that their private medical information can be shared with the state of Minnesota if their claims reach the reinsurance attachment point. Not only will enrollees not be able to opt out of this data sharing, but we see no requirement that they be notified that their data will be shared when they reach that reinsurance threshold. We wonder if enrollees will be given a Tennyson warning as required under Chapter 13. Since 2017, more than $1 billion taxpayer dollars have been spent on this program. Senate File 333 proposes an additional general fund transfer of another $512 million in fiscal year 2026. Will this cost levied against all taxpayers and redistributed to health plans continue year after year or even increase if reinsurance continues? Under this bill, this redistribution system will continue transferring dollars from the pockets of taxpayers to the health plans for years to come. Instead of supporting Senate File 333, we would encourage this committee to add flexibility, freedom, and choices to Minnesotans by repealing the plethora of costly health care mandates on insurance companies so that consumers are not limited to one-size-fits-all insurance options, or to allow insurance companies to offer more affordable mandate-free policies, or to enact the less expensive health benefit plans offered through the Farm Bureau, which are available in 7 other states. For these reasons, we urge this committee to oppose Senate File 333, and thank you again for the opportunity to testify to our concerns.
Thank you. Thank you to all the testifiers. That's the conclusion of the testifier list that we have. Members, do you have questions or comments on the bill? Senator Udke.
Thank you, Madam Chair. And I guess my comments will be that over the last number of years, starting in 2018, we've seen the success of this program. It's done everything we had hoped it would do. And I hear comments about it's transferring money to insurance company, money from taxpayers to our insurance companies. The insurance companies aren't sitting there getting rich off of this. They're paying the bills. It's money in, it's money out. They collect premiums to pay claims. And, you know, at times maybe we need to do an insurance 101 to just go through how this system works. They're regulated, heavily regulated on how much they have to pay out in premiums and what they can use for overhead, et cetera. So it goes back to, this has been a product that has proved to be successful. And I guess across the board, I think we're seeing that everybody agrees reinsurance is needed. Even the governor's budget proposal has reinsurance included. The conversations or the arguments will be, how do we pay for it? And, you know, this proposal before us is using the plan that we've been using, and at this point, I think it's still the best plan we've seen. So I would encourage support for this Senate File 333.
Senator Mann.
Thank you, Madam Chair. So when we talk about insurance mandates like the ACA, where everyone pays to buy insurance and then everyone gets insurance, people were like, no, that's socialism, we can't do that. Okay, so then we talk about universal health care when everyone has to pay and then everyone gets insurance. People are like, no, we can't do that, that's socialism. All right, so now we're talking about taking taxpayer money where everyone is paying, and then we're giving it directly to the insurance companies so that not everyone gets insurance. We're like, yeah, that's the way to do it. Like, someone explained that to me. That is ludicrous. And I love the comment of in 2017, we're like, this is going to be temporary. So it's going to be temporary that we're going to take taxpayer money and we're going to give it to insurance companies. Like, we're going to give them hundreds of millions of dollars, and then they're going to turn around and they're going to get to keep all the profit, and they may or may not decrease premiums. It's going to be up to them. We're going to leave it up to them. And then we're going to ask them to decrease co-pays, and we're going to ask them to decrease premiums and lower the price of drugs, and they're going to say, we probably can't do that. but it's going to be temporary. We're going to do this program temporary. Why would it be temporary? Why would they not come to the table year after year and say, let's do it again? And if you don't, we're going to increase your premiums. Of course it's not temporary. Of course we're going to do it every time. Of course it's going to keep going. It just boggles my mind that we're sitting here doing the exact same thing over and over again, and the prices are not getting better. We're not providing health care to people. People are still saying, I need health care. I still can't afford my medications. I still can't afford my premiums or my copays or my deductibles. It's not improving. And yet, I mean, the definition of insanity, right? We keep doing the same thing over and over again without any different results. The other day in this very committee, we called people who use MA like irresponsible and lazy, but because they're using government money to get their health care. But when we do that to insurance companies, they're heroes, right? Because they get to keep the premiums down. But they're not irresponsible or lazy. They're awesome. So I don't get it. I hate the idea of reinsurance. The other thing is I don't understand how long we're going to keep using taxpayer dollars to subsidize private insurance companies. And lastly, if the federal government doesn't do this, we're going to be on the hook for it. So are we ready for that? I guess that's my only question, Senator Dahms. Are we ready for that? If the federal government drops the ball, what are we going to do?
Senator Dahms.
Thank you, Madam Chair, and thank you, Senator Mann. A couple of things I think we need to go back and talk a little bit about. When this was first put into place, we were trying to salvage a market in rural Minnesota. We had counties that did not have people selling insurance in those counties. And what caused all this to crash in Minnesota was Obamacare. That's where this all started. And we're still trying to dig out from under that. And so Minnesota, back in the days before Obamacare, we were some of the highest. We had some of the highest insurance ratings in Minnesota. Minnesota ranked very high with the insurance we provided. When Obamacare come along, we had to apply for a waiver not to get rid of some of those high-end policies that we had for the people. So we are here today, yes we are, and we're not asking for the waiver, we're asking for the money to put into it. We did try subsidies for 1 year, and we found out how well that did not work. We could go back and we can assess the insurance companies. If we want to do that, we can do that. But all you're doing is just moving the dollars around. The premiums are going to go up because you're moving the dollars. We talk about, you get concerned about the for-profit insurance companies. If you take a look at that, Dan Andreessen, take a look at those reports he has, you can look into there. And if there's fraud, go through there and find it. We'd be more than happy to deal with it if you can find the fraud. What's very interesting is when we first put in reinsurance to salvage the marketplace, there was a lot of talk about it doesn't drive the cost of premium down. What is part of the subject today? It doesn't drive the cost of insurance down. It doesn't cost of medication down. It doesn't reduce the cost of medical care. The only people that can do that are in this room and are on our senators and legislators. If we're going to do something, it has to come through us to start reducing these costs. Yet, day after day after day, we sit in Commerce and people are coming up with more mandates they want to put on the insurance companies, and they don't want to pay for them. That's going to drive the cost of insurance up. And it's going to drive up the cost of insurance, which drives up the cost of medical care for people that are buying insurance. So we have to decide, what do we really want to do? We want to just use lip service and talk about how we really need to reduce the cost of health care? Or do we want to step up to the plate and say enough of all the mandates and try to keep a reasonable policy that does reasonable things?
Senator Mann.
Thank you, Madam Chair. Thank you, Senator. So that didn't answer my question. And first of all, in 2017, there's no basis to say that the subsidies did not work. But regardless, what's going to happen this time around if the federal government does not approve the waivers?
Well, the same thing
Senator
would have
Dahms.
happened had they not approved the waiver back when we first got it. And when we got it under Biden, we got the money. And I don't know where you're going to get that we're not getting the money other than a scare tactic. It seems like you folks have gotten really on the bandwagon to talk about the federal, but not talk about our local. We're in a financial crisis locally, and that had nothing to do with the federal system. As far as asking the question, am I prepared for that? I guess we're as prepared as we can be. And you're right. If the federal government doesn't give us the money, we will end up paying it. That is true. But if we're going to make every decision around here, assuming the federal government is not going to give us any funds, we got a long 2 months ahead of us. And I hope that you remember that when we're working on other spending and stuff, that if the federal government doesn't give us some money, where we're going to be at. I think right now the federal government, when we take a look at the total spending in Minnesota, I think between 35 and 40% of that money in our total spend comes from the federal government. So this is going to be a small part of that headache.
Senator Mann.
Madam Chair, I don't think it's hypothetical, Senator. The last time the Trump administration held office, our reinsurance waiver was only partially approved because the administration at that time denied federal funding for Minnesota Care. So I think these are very valid questions that we do need to think forward to and have a plan in place instead of being caught not knowing what to do when these funds don't show up. Thank you, Madam Chair.
Members, any other questions or comments? Senator Dahms, just to reinforce, I guess, what Senator Mann was saying. I mean, we did see over the first years of the Trump administration that we didn't receive the money, and we are actually, when you look at the table of federal funding for the plan years, we had to put in $33 million more of our state funding than we would have. So I think, we do need to think about that as we look at solutions to help this market. And then just in terms of the statement you made about the money that still remains in the account, when we budgeted for the last 2 years of reinsurance, we allocated as a legislature a specific amount to cover those 2 years. The amount that is remaining in there, it came about because of changes in terms of what we received from the federal government over time versus what we forecasted we were going to need. And also if there were program estimates that turned out to be less than what we allocated. So the amount that's there has, that we reallocated was not ever intentionally allocated by the legislature for reinsurance. So it's one thing to say that it is sitting there, that may be true, but we have to make legislative decisions about allocating the money and the $512 million that it would cost if we needed to do that. That would have to be actually specifically allocated by the legislature. I think my concerns about reinsurance and moving forward this year relate to the uncertainty with federal funding. We do, if we need to ask the federal government for additional waiver parameters or make changes, I think there is a risk to our funding for Minnesota Care and, for what we would be able to take in for the reinsurance program. I think that is a risk, and we need to be clear-eyed about that as we talk about solutions for this particular issue. And we don't see reinsurance, itself as really addressing the causes of high healthcare costs, which is a concern for me as well. So while I understand your interest in having the waiver process extend going forward, ongoing, I really don't think that's the best way for the legislature to make decisions about a program like this. I don't think that we should just put the waiver process as an ongoing mechanism. We need to discuss it. We have to discuss the funding mechanism each time, and I don't think it's a good idea to put that waiver process ongoing without without a stopping date. So, members, any other questions or comments? Otherwise, I'll turn to Senator Dahms for closing thoughts.
Yes, thank you, Madam Chair, and members for hearing the bill. Just a couple of things I want to bring up is there were some comments just made about the federal funding and how under Trump, and I guess it wasn't specifically said Trump, but it was that era, that we did not get the waiver money. Well, that we did get one piece of the waiver. We did not get the second piece of the waiver. I don't have the numbers in front of me to calculate that back to 5 years ago to see what that money would have been. Right now, it's about 29, almost 30 million for that second piece. So we've always got the first part, and at this point in the road, it's about 100 million. And so that's, the other thing is that in the bill, if there's no money set aside for the reinsurance, then you wouldn't be getting the waiver. The other thing is that, Madam Chair, I think I heard you say, but please correct me if I'm wrong, I think I heard you say that if we start changing the waiver and stuff, it might have an impact on the money we would get from the federal government. Was that correct?
Senator Dahms, I said that it might affect it because the federal government may relook at and may change plans as the Trump administration did in 2018 or 2017-18.
So can I ask, what was the comment you made about if we asked for changes in the waiver? What was your comments on that?
Senator Dahms, if Commerce has to apply for the waiver, if we make any changes in the parameters or in the funding, I believe that Commerce will have to go back and submit that information to the federal government. That's all I was referring
thank
to.
You. Yep, thank you, Madam Chair. Well, thank you, Madam Chair and members, for hearing the bill. We do appreciate it. And as I understand, the bill is going to be held here until you get your targets. Is that correct?
Senator Dahms, yes, we're planning to hold, to have it stay here in the Health and Human Services Committee because it doesn't need to go to any other committees in the Senate except to Finance. And since we don't have current information, we don't have our targets set, we don't know if the reinsurance, if it would be something that is part of the HHS target or a separate target. All of that discussion is really ongoing right now. So right now it's best for us to keep it here. And then when we have more information, then we can make a determination about what to do next.
Thank you, Madam Chair and members.
Thank you. And with that, Senate File 333 is laid over. And now we move to Senate File 1024.
Madam Chair, to Senate File 1024 when you're ready. You have an A1 Authors Amendment.
Thank you, Madam Chair. Yes, I have an A1 Authors Amendment. It's a technical amendment that corrects some things and makes a change based on feedback that we received from MNsure.
Senator Wiklund moves the A1 Authors Amendment. All those in favor signify by saying aye.
Aye.
All those opposed? The A1 amendment is adopted. To the bill as amended.
Thank you, Madam Chair. Thank you for hearing Senate File 1024 today. The reinsurance program has been the topic of a lot of discussion, as we just witnessed, in the legislature since it first passed in 2017. The legislature has voted a handful of times to add additional years of funding and reauthorize the federal 1332 waiver to operate and help pay for the program. However, each time the legislature faces a decision on the future of the program, we spend a lot of time talking about the merits and flaws of the program, but we rarely spend much time digging into possible alternatives and ensuring we are making a fully informed decision about the best path forward. It's important to say clearly here that I believe allowing the reinsurance program to end with nothing to replace it is not the right solution for Minnesotans or the stability of our individual market. Reinsurance is an important program that has helped provide stability in the individual market, but it comes with a large and increasing price tag. It's also very complex, and its existence has not come without challenges. For example, for the first 5 years of reinsurance, the state was also penalized for having our basic health plan, also known as Minnesota Care. Reinsurance affects the amount of federal funding for Minnesota Care, and though the state asked the Trump administration back in 2017 if it would hold Minnesota Care harmless, it did not. We know that Minnesota receives federal pass-through funding to help pay for the reinsurance program. However, it's less widely known that the amount of federal pass-through we received for those first 5 years, 2018 through 2022, was less than the total amount we had to spend to fill the hole created by the loss of federal funding for Minnesota Care. The net loss to Minnesota during that time was about $33 million. And you have a table in your packets that shows the various numbers for each year. It was not until 2023 that Minnesota received a permanent reprieve from the Biden administration that Minnesota Care would no longer be penalized. We are currently facing increasing uncertainty at the federal level, and we have the opportunity now to look into viable alternatives to the reinsurance program that maintains stability in the market and have the benefit of untangling ourselves from the federal government and the challenges and hoops of the 1332 waiver process. It is my hope in bringing Senate File 1024 forward that we have a serious discussion about the merits of both reinsurance and this reasonable alternative, including an honest assessment of both proposals, flaws, and risks. And while we do not know how likely or how easy it would be for the Trump administration to attempt to reinstate the penalty on Minnesota Care, we do know that such a change would have serious implications for the state's budget at a time when we know we have fewer resources to address them. Based on projections from DHS, the penalty for reinsurance on Minnesota Care would be $149 million per year. The latest projection from the Commerce Department on federal pass-through for reinsurance is $100 million per year. This means we could return to a time when having a reinsurance program is not truly a net benefit to the state. That's why I brought this bill forward, and I'm glad to see the fiscal note arrive just in time yesterday for this hearing. It shows that the state share for reinsurance and the state costs for the subsidy program are generally in alignment. And while there is more work to do getting the bill in the right shape, it gives us the information we need to demonstrate that the subsidy could be the right path forward. With all this in mind, I will share more about the specifics of the bill and the subsidy. This bill establishes a premium subsidy for people buying insurance in the individual market, both on MNsure and buying off the exchange directly from insurers. The subsidy is set at 20% because it is meant to replace the effect of the reinsurance program, which has lowered the underlying rates for insurance plans sold in the individual market by about 20%. The subsidy is designed to seamlessly replace the effect of reinsurance for those who benefit from the program today in a clear and more transparent way. And it reduces the total cost of the program by targeting state dollars to those who need it. Under reinsurance, we buy down the insurance rates for everyone in the market, but people receiving advanced premium tax credits APTCs, do not need reductions in the underlying rates because their tax credits flex to account for those changes. By changing the program to a direct subsidy, we remove this inefficiency in the program and target payments to only those who do not get tax credits. MNsure would administer the program and display the subsidy in their shopping experience so people will see the subsidy they are eligible for when they are shopping for their plan. When insurance companies bill enrollees each month for their premium, their bill will display the 20% discount and the net premium they need to pay. MNsure will reconcile these discounts with the insurance companies so that enrollees do not have to do anything except pay their premiums as they normally do. This is set to be a forecasted program, so there will always be funding for those that are eligible and enrolled in a plan. And finally, under the subsidy, there is no need for a federal waiver and no risk to Minnesota Care. The state will pay the full cost of the program, but as the fiscal note shows, the overall size of the program is less than the overall size of the reinsurance program. And I do have some testifiers here today to speak to the bill.
Thank you, Senator. Olivia Bergen and Stu Lowry can come to the table. Please introduce yourselves and proceed.
Chair Wiklund, members, good morning. My name is Olivia Bergen. I'm an organizer in Rochester with Isaiah. And today I'm asking you to support Senate File 1024, which would replace the reinsurance program with direct consumer subsidies. Every Minnesotan, regardless of where they live, what kind of job they have, how much money they make, should be able to get great quality and affordable and accessible health care. But because of health insurance companies' greed, that is not our reality. For 5 years prior to my current job, I worked temporary jobs at small employers. I ran my own payroll. I bought insurance on the individual market. And I spent thousands of dollars in premiums each year, still had to pay and meet a $9,000 deductible before my insurance would cover anything. Every year, it took me a day or more of research to figure out which plan was the least bad option. And a lot of the choices weren't really health insurance, they were bankruptcy insurance. I was one of those consumers who reinsurance was supposed to be helping. Since 2018, it's been a $1 billion giveaway to insurance companies, but it might not have actually been helping me at all because half of reinsurance funds just offset federal advance premium tax credits instead of actually saving consumers money. Moreover, under the last Trump administration, Minnesota lost out on $700 million of federal funds that would have gone to Minnesota Care to help more people access health care. Consumers need relief, and Senate File 1024 delivers that directly to people, your constituents, not health insurance corporations in a highly profitable industry. It's more efficient, it's more equitable, it doesn't put Minnesota Care at risk. And we would know transparently that rates are reduced 20% for everyone, not on average 20% less than would have been charged. The industry has testified today, what's so great about reinsurance is that it's invisible to people. It's non-transparent. People don't actually know how it's benefiting them. Furthermore, we should pay for this through an MCHA assessment or another source of new revenue. Minnesota has excessively subsidized this industry through reinsurance, paying 2 to 20 times as much as other states. It's fair that they contribute to the stabler market that they benefit from. I just want to close with a question that as an organizer, just like all of you as public servants, I talk to a lot of people in the community who are concerned about healthcare costs. I am wondering, do any of your constituents really tell you that health insurance companies are not being treated fairly? Won't someone please think of the health insurance companies? I do not hear that from people in the community. So please support Senate File 1024 so Minnesota families' health care can remain in reach.
Thank you, Ms. Bergen. Stu, go ahead.
Thank you, Chairman and members of the committee. For the record, my name is Stu Lowry, Government Relations Director for Minnesota Farmers Union, and on behalf of our members, I'm glad to share our support for Chair Wiklund's SF 1024 to create a direct subsidy program for folks purchasing insurance on the individual market. Of course, farmers are small business owners, so they disproportionately don't get insurance from an employer, and they often purchase insurance on the individual market, and they're facing unsustainable costs there. I'll say, both for their premiums and, as has been mentioned in this conversation, also their cost share. And that's why for years we've been before this committee and others advocating for Minnesota Care Public Option, which is also an intervention in the individual market. But one thing that we've learned from those conversations and work with our members is, of course, no surprise, farmers' incomes are widely fluctuating. And so a lot of our members who are struggling with costs on the individual market, the next year they may be on Minnesota Care, and they're grateful for that coverage. They rely on it. So it's really important for us to find a solution that doesn't risk that adverse interaction and the potential for the new administration to reinstate cuts to Minnesota Care. There's potential there that we could hurt the same families who we're trying to help and rely on the individual market in some years. And I'll just say from talking with our members, this coming year could be challenging financially for family farmers. I think it's quite likely that more folks will be income eligible for Minnesota Care coming out of this year. Just one data point, in the early part of this year, farmer lender mediations, farmers facing the potential of foreclosure, we're up 300% from the previous year. So obviously that's a topic for the Agriculture Committee, but relevant here as we think of, our members who we represent who may rely on Minnesota Care. So I appreciate Chair Wiklund's hard work on this, as with so many other things, and glad to share our support. Thank you.
Thank you, Mr. Lowry. Dan Andreessen and Mike Anderson, please come down. Mr. Andreessen, introduce yourself and proceed.
Madam Chair, members of the committee, Dan Andreessen with the Minnesota Council of Health Plans. First, want to thank Chair Wiklund for bringing forward alternative ideas. I think we're always open to looking at them, and I think it's important to kind of look at all options on the table. And we think that looking at premiums or subsidies is a worthwhile idea to debate. The state did use subsidies for 1 year, so this isn't necessarily a foreign concept. However, if we're looking to replace the reinsurance program with state subsidies, they're not necessarily the same program. I think it's important to kind of look at, the trade-offs between the two. With subsidies, the way that it's drafted in the bill, they would only apply to people with incomes over 400%, so it's people who are not getting APTCs right now. This would be different from the reinsurance program, where regardless of your income, you're benefiting from the program. This would likely run through the exchange. Typically, I know it's kind of maybe ambiguous in the bill language as to how this would work on or off exchange, but our reading is that it would probably have to work through MNsure on exchange. In the fiscal note, MNsure states that 77% of the individual market is on exchange. Therefore, 23% is off the exchange, and they would either need to go on the exchange to get the subsidy, or they would not get the subsidy at all. The state subsidy program would be entirely using state money. The reinsurance program is able to leverage federal money. So if we're not doing that, we're leaving money on the table. State subsidies would count as taxable income on your federal tax return. So if you're getting a subsidy, you would need to account for that. Right now, there's no tax impact to enrollees with reinsurance. And also in the fiscal note, MNsure states that there would be need for significant investment for them to do this. They stated needing resources to do an IT build, and that the first year they would need to use a manual process for processing the situation. And then also they would need 27 and a half FTEs in 2026 and up to 44 in 2029 to run this project. Right now, we don't need any new investment to continue the reinsurance program. If the legislature does want to go in this direction, the council does suggest actuarial modeling to be performed on this proposal prior to enactment, just so we can measure all the potential impacts. It's been 7 years since Minnesota tried this approach, and at that time, the subsidy ran through health plans rather than MNsure. Also, much of the insurance market has changed in 7 years. We're also concerned about MNsure's acknowledging that in their fiscal note that the program can't be implemented until 2027, which means there'll be a gap on premium assistance in 2026 if reinsurance is ending it this year. Also want to mention language that was posted in the A2 amendment for an assessment. We do have concerns about this rather than using general fund money to pay for it. As I stated in my previous testimony, health plans are already currently paying taxes, and any of these taxes could be dedicated to a subsidy program if you wished. The way the language is drafted in the amendment, the assessment will only fall on 5 health plans who are in the reinsurance program. Quartz, which is a small nonprofit out of Wisconsin that's serving 1 or 2 counties in southeast Minnesota. Blue Cross Blue Shield of Minnesota, Health Partners, Medica, and UCare. So those are going to be the insurers that are taxed in that assessment. All these nonprofit plans have 1 to 3% margins. And so any tax will fall on new enrollees, reducing the effectiveness of a subsidy program and premiums paid by policyholders. Thank you, Madam Chair.
Thank you, Mr. Andreessen. Mr. Anderson.
Good morning again, Madam Chair and committee members. My name is Mike Anderson, and I'm the past president of the National Association of Benefit and Insurance Professionals of Minnesota, and I'm an independent agent serving individuals on and off the exchange and employers in Minnesota. I'm here to respectfully express our concerns on Senate File 1024. If this is seen as assistance in addition to reinsurance, that is great. However, in the past, this concept has been seen as an alternative to reinsurance, and it leaves many Minnesotans behind. Lines 2.16 and 2.17 make it clear that if you already get advanced premium tax credits, you're not eligible for the premium subsidy program created by this bill. Those who get a federal tax credit also benefit from the reinsurance program. If reinsurance is not renewed, they could get up to a 25% premium hike, and they won't benefit from the program. Large and small employers utilize ICRA, individual coverage health reimbursement arrangements, that allow their employees to buy individual plans in the market. So they currently benefit from reinsurance. It is unclear if they would be eligible for this plan, so they would likely get a 25% premium increase as well. If this bill is meant as a replacement for reinsurance, it not only will leave many reinsurance beneficiaries behind, but it will not have the stabilizing impact of the market that reinsurance has by design, which absorbs the risk of high claim individuals. We urge legislators to dig deeper into these questions, and we are opposed to the use of this program to replace reinsurance.
Thank you, Mr. Anderson. Matt Flanders.
Good morning again, Madam Chair and members of the committee. My name is Matt Flanders, and I'm the Legislative and Policy Director at Citizens Council for Health Freedom. Thank you for the opportunity to provide testimony and share our concerns with Senate File 1024, which would create a premium subsidy program administered by MNsure. This bill, number 1, increased costs to taxpayers. Number 2, further entrenches an unnecessary government agency. And 3, fails to address the reason premium costs are ever increasing. Government subsidies are in fact taxpayer-funded subsidies and only artificially reduce the cost of health insurance premiums. Senate File 1024 would use taxpayer dollars to fund a premium subsidy program with the appearance of reducing the cost of health insurance for consumers. This structure only makes insurance look cheaper to the consumer, who likely has no idea that their tax dollars are being used to subsidize their health insurance. We also have concerns with this program being administered by MNsure, an unnecessary state-based exchange. Ending MNsure would save taxpayer money while still allowing Minnesotans the ability to access health insurance through the federal exchange. Rather than further entrenching MNsure by adding another program to it, we suggest getting rid of MNsure altogether. Based on our analysis of Senate File 1024, we are uncertain if an eligible individual who pays the net premium would be notified about being in this new program or how much of their information would be shared with MNsure. Lines 3.25 through 3.27 require the MNsure board to develop a form for verifying a health plan's reimbursement request, and we are concerned that an individual's private information would be shared, perhaps without consent, as part of the premium subsidy approval process. After reviewing the fiscal note for this bill, we are also concerned with the cost to taxpayers to the tune of $112 million in 2027 and a drastic increase to $279 million 2 years later in 2029. Throwing money at the problem of rising health insurance premiums may make consumers briefly experience less expensive premiums, but does nothing to tangibly make health insurance cheaper and more accessible to Minnesotans over the long term. We would encourage this committee to consider the same options we provided in testimony on House File 333, which would make healthcare more accessible and affordable, including repealing costly health insurance mandates or allowing for mandate-free policies, or passing legislation to authorize farm bureaus to have affordable health bureau or farm bureau plans. Thank you for the opportunity to provide testimony on this bill and for listening to our concerns.
Thank you, Mr. Flanders. Senator, any thoughts before we go to member questions?
Thank you, Madam Chair. Yes, I'd just like to mention a couple things. Mr. Andreessen listed a number of things that I don't think portray the bill accurately. I guess I'll just, two of them that I want to comment on. The program would be, it would be possible for people to buy their insurance off the exchange without going through the marketplace. I mean, if we forced everybody to use the marketplace, that would be a distinct statement that we would be making, but that is not the intent or the rationale for this subsidy. It would be possible for people who are buying their insurance off the exchange to receive the subsidy. And then as far as the APTCs, I think, and that this would only apply to people over 400%. It would apply to people under 400% as well, and our intent would be that people would be able to see the effect through the shopping experience and be able to select the subsidy, and if it was superior to the APTC effect. So it isn't that we just cut off everybody. So that, I just wanted to mention those two things, and there were other items that I would like to clarify and would be happy to sit down with the health plans and go through it in more detail.
Members? Senator Rucky?
Thank you, Madam Chair. And a number of these things have been covered as testifiers have talked about it, but you know, on page 3, line 19, it talks about eligible individuals. I think I know where you're heading there, but is that just confirming that everybody with over the 400% would not receive a subsidy?
Senator Wiklund?
Senator Utke, people who are not eligible for the APTCs, if they're over 400%, they would be eligible for the subsidy. Yes, they would be.
Senator Rucky?
Thank you, Madam Chair. But I've been hearing that some would not be eligible for subsidy. Where does that line, where's that line drawn?
Senator Wiklund?
Madam Chair, Senator Utke, I believe that the people, if they were to receive an APTC that is above what a subsidy could provide, they could receive that and choose not to partake in the subsidy. But for most people, the subsidy would be greater and have a greater impact.
Senator Rucky?
Thank you, Madam Chair. I guess I unfortunately didn't follow all of that, but you know, I've got a number of concerns with this. I mean, from the fact that the subsidies are taxable income, which actually reduces the value of this subsidy. The subsidy is set at 20%, which is coming in under what we're being told the increases will be in insurance to their insurance premiums. So in the end, they're going backwards as far as the consumer that's buying their health plans on the individual market. Which includes the individual and small groups. The number of FTEs, of course, is very concerning. We're growing another agency. And then when I look at the cost on that fiscal note, when we go out into the tails, there is no savings on this plan. It equals, if not a few dollars more than what we just saw in the reinsurance bill right prior to this. But it all falls back on, you know, I've heard farmers come up in a conversation, and that's one group that comes up a lot. Farmers and our small business owners typically are all in the same. They are buying their health insurance on the individual market. And in 2016, we saw a lot of those types of people that were telling me they were going to go without insurance if something didn't change because they couldn't afford it. Now, these are people that have worked, and the ones I was talking to were, had been either farming or in their small businesses for many years, and they were just under Medicare age, and they were saying, we can't do this anymore. We're going to probably go without insurance. Now they'll put every asset that they've worked their whole life for on the line because of, you know, basically rolling the dice that they wouldn't need to go in for a major medical procedure. I see this putting some of them back in that same position. If we get to those that don't qualify for some of these lower end subsidies, and it just is, it's putting them in a position that they shouldn't be. And I would have extreme concerns about, you know, what this is actually doing. So with that, I hope we go to something that treats them all equally and fairly. We do need to, I think, you know, like I mentioned before, everybody recognizes we need to do something. We got to do something related to reinsurance to be able to buy down those premiums a little bit. And but I'm very concerned with what I'm seeing on this one. So thank you, Madam Chair.
Senator Wiklund.
Madam Chair, Senator Utke, I think, you know, the goal of the program would be to provide the same type of lessening of a premium increase as reinsurance does. So we're not trying to leave anyone out of the current who is affected currently by reinsurance. And so if there is an aspect to how I've gone over this that conveys that we would be leaving some people out, that's not the intent. And we will work on clarifying the language to make sure that people are included because it is meant to be a similar experience for people. They will see a 20% lower increase or lower amount on their premium. And we chose 20% because that's what we keep being told, that reinsurance, the effect of reinsurance is to keep rates from increasing by 20%. And that doesn't include, you know, they have increases in their rates each year that are beyond that. So people do experience increases in their rates. So the intent is to be similar in experience to what reinsurance provides today and not leave people out. And people who need the subsidy will be able to receive it. And currently, if people receive an APTC, that actually changes in response to rate increases. So it has a threshold of their income that is meant to be protected, and as rates increase, the tax credit will increase. So that's why there's an effect by people receiving APTCs that they are accommodated today, and we use the reinsurance program. It doesn't differentiate between people who are already able to experience a lack of increase in their rates because of the APTC. And in terms of the program, the fiscal note is covering more time than what the reinsurance proposal covers. It covers 2.5 plan years. So I think we need to make sure that when we talk about the cost over time, what we can see from the fiscal note and comparing it to reinsurance, the subsidy state total has a potential savings each year over what the state share of the reinsurance program would be. So we can work on providing you that information to clarify that.
Senator Utke.
Thank you, Madam Chair. A follow-up to that is this bill is proposing everything coming from the general fund, or is there any other sources? I know that there was some proposed language that hasn't come forward on this, but there would be taxes on the plans, providers, et cetera. But these dollars are strictly from the general fund, correct?
Madam Chair, Senator Edke, the current, the bill as amended so far, it would allocate the money from the general fund. I do have the A2 amendment, and if I could move that, then we could talk about that, Madam Chair.
Senator Wiklund moves the A2 amendment.
Members, this A2 amendment is meant to bring forward a mechanism for paying for the subsidy program using the tax that, or the assessment that the governor's proposal utilizes. It's meant to be presented today as an example of a possibility for covering it without using general funds. And, you know, as the governor had introduced, the assessment was on MNsure members. I think there's more work to be done to assess who exactly that would fall on and how the assessment would apply to each impacted member. And so I do bring this forward with the idea that there is more work to be done, but I did want to raise it for discussion because I do think that we should be looking at alternative mechanisms to pay for whether it's reinsurance or whether it's a subsidy program. I think that many states today do utilize a form of assessment to cover the costs for the state to provide a reinsurance program, and I think Minnesota should seriously look at that. I think that that's a more fair way to cover the costs and would be something that I'd like to bring forward. So I'll put this out there for discussion, and I don't want to take a vote on it today, but I do, if you do want to discuss or ask questions about it.
Members, discussion on the A2 amendment. Senator Abler.
Well, thank you. And, you know, this is actually a really good discussion on the whole idea. And probably going forward, we need more discussions like this on all kinds of topics. How are we going to manage to deal with a negative target in this committee sooner or later? I don't know if it's going to be negative leaving the floor on the first round. But so we really have some serious things to talk about. And I appreciate Senator Wiklund for delving into this and bringing up an alternative. I remember on the reinsurance, I favored the Alaska plan. I didn't prevail. Would that have worked better? I'm sure it would have, but I don't know. And so how do you handle high health costs? And that's really the topic that we're dealing with here. And the people in the audience represent various people and have their own opinions, and smart people everywhere debate it. ACA was supposed to be helpful, and I didn't think that was the way to go back then. But anyway, so here we are. So thank you for bringing that up. I just wanted to comment to the amendment that there's about 1 million people covered by Minnesota health plans, 600 some thousand in the large market, 200 some in the small market, 120 or so in the individual, 20,000 by their own, I think, that are covered by this topic. Unfortunately, the self-insureds and Medicare, Medicaid we control Medicaid, but so there's still 1 million people affected by this, and I just wanted to remind everybody what they maybe already realize is I'm not a big health plan fan, we've discussed that, but they're kind of a necessary, I won't use the other word, but they're necessary. Well, this starts with E, but it's essential. They're necessary and essential. At least they're part of what we have set up here. And so, but like the governor had this, like, oh, make them pay their fair share. Unfortunately, with the ACA, they got rid of their loser plans, which were actually the nice ones that actually were useful. They had reasonable deductibles, and we've got these high deductibles now. And I don't know how to contain their cost arrangements, how they spend their money. But even so, it seems like they're not going to absorb the costs when they're taxed within, but simply will pass it through. And I don't know how to remedy that, and if that's the case, if we charge, $1 billion worth of healthcare taxes of various sorts, which the governor seems to get pretty close to that number, that's going to be $1 billion pass through to the very people buying it. And so what is going to happen is they're going to nick up the price just on the market, but also on MNsure, when the prices go up because of the pass-through, that's going to increase the need for more subsidy, which is actually going to deepen the federal deficit and put more pressure on Medicaid funding, which Senator Mann and I do not disagree so much on a lot of this stuff. We just are really frustrated and toward the point of trying to help the people. And so, but I would vote no on this amendment if it were brought up, but I wanted to just say those comments. I don't know how we're going to afford either plan for cash, and that's really a problem. But I just wanted to thank you for trying. If the bill's going to move, I'll vote to move it so that the discussion can go forward. But thank you for the discussion, and as an exemplar of many discussions we'll have to have going forward. Thank you.
Senator Liskey.
Thank you, Madam Chair. Thank you, Senator Wiklund, for bringing ideas forward. I unfortunately don't know that I can support this idea, especially the A2 amendment. You know, the thing I get concerned with reading through it just on a base level at the moment and having an understanding, maybe I'm misunderstanding, but basically we're going to tax the plans to then turn around and pay the plans back to keep their premiums down. And I just don't see how that's going to reduce the cost of healthcare. You end up just creating another third-party payer involvement, and you just end up taking a percentage out of that tax to pay the people that collect the tax, and then turn around and give it back to reduce the premium by less than what you would have reduced if you'd have just reduced the premium. I don't, you know, Senator Mann said some pretty thoughtful words earlier, and I think I share a similar feeling, not always the same exact way, but no matter which idea we're in here in the reinsurance plan or in this subsidy plan that you've brought forward, I'm concerned no matter what we do, we're subsidizing health insurance, and it's not going to reduce the costs the way our goals are. I think we need to start coming up with even more ideas that can maybe change the landscape. I don't know that the universal health care or the single payer option is the way I'd like to see it go. I would actually like to see it go to more options, not less, because I think the more competition there is, it drives the cost down. The concern that I have is this is just going to continue the same path. I'm thankful that you're bringing a new idea. I just don't know if this idea is going to solve it any more than the other ideas that are brought forward currently. And so with that, I would be a no vote on the A2 just because, like I said, unfortunately, it would be just a tax that we would collect and then turn around and use to pay some of the reverse back. So I don't think it solves that problem. And then the underlying bill, I feel like it's very similar to reinsurance. And I'm concerned that we won't be able to leverage federal dollars then. And so really, where's the gain, or is there a loss? And I get concerned there. So with that, hopefully we can keep having these conversations, and I look forward to working with you on trying to find the solution.
Thanks. Senator Wiklund. Other questions, comments on the A2? Senator.
Thank you, Madam Chair. And I just wanted to add, I don't like taxing the plans at all, because that just, again, it just moves the cost on to others. I show that the plans are already taxed at an 8.86% rate. This is going to drive that up. Doesn't take much, and we've got over a 10% tax on what people end up paying on their premiums. So that type of move just is basically a non-starter as far as I'm concerned. I think we're not addressing the true costs of health insurance. This definitely wouldn't drive down the cost of health insurance for the average person buying an individual and small group market. And so I would not be in favor of the A2 also. Thank you.
Senator Kubek.
Thank you, Madam. Wow. Thank you, Madam Chair. Holy cow, that was really bad. Just curious, so I'm looking at a list of other states here that do this with an MNsure fee. A lot of them. So I'm just curious, how does it work in the other states that they're able to do the MNsure fee and fund their program that way? Some of them, they're all kind of if you do the population math, it's close to Minnesota. So what we're talking.
Senator Wiklund.
Thank you, Madam Chair, Senator Kupek. States use various mechanisms. I'm just looking, I have a chart, if you would like, I can share with you that the universities, SHADAC Research Center had put together a list that lists all of the states that have a reinsurance program and kind of their parameters. It's similar to that, but it's actually got more detail than the handout we have. So they use different mechanisms, but most of them, I believe, are taxes on the plans that assist in paying for the reinsurance program.
Senator? Okay.
If there's no further discussion about the amendment, I'll withdraw the A2 amendment.
Okay, the A2 has been withdrawn. Any further questions on the underlying bill? Senator Utke?
Thank you, Madam Chair. And I just wanted to go back to that underlying bill because we spent a lot of time talking about it on the bill previous to this, and that was the waiver, the 1332. There is no plan to apply for a waiver with this proposal. Is that correct?
Madam Chair, Senator Utke, there would not be a need to for this program. We do not need to go to the federal government. We would be choosing to use our state dollars or assessment income or revenue to fund the program.
Senator Utke.
And I'll just say that, I mean, I think the positive things about talking about a subsidy program is that it doesn't require us to apply for a waiver, and the introduction of the risk of changes to federal pass-through dollars that might be made, decisions that might be made at the federal level that would affect our pass-through dollars or funding for Minnesota Care. So to me, that is something that we should strongly consider as we develop a solution for funding a subsidy or a reinsurance program this year.
Senator Utke.
Thank you, Madam Chair. And I do have a question as to the plans for the bill. What is the plans going forward?
Madam Chair, Senator Utke, the plan is that this bill would need to go to the Commerce Committee and to Judiciary because there's data sharing pieces in it. And so my desire is that we could move the bill from this committee and send it to Commerce and then to Judiciary, and then it would come back to the HHS committee and be here available or for more discussion than when it comes back.
Senator Utke.
Thank you, Madam Chair, and thank you, Senator Wiklund. That was my concern as far as where it's going. So it will come back and park here alongside the other one once you've made those two stops. So
yes.
Thank you for that.
Okay, seeing no other questions, Senator Wiklund moves that Senate File 1024 as amended pass and be referred to the Committee on Commerce. All those in favor signify by saying aye.
Aye.
All those opposed? The motion prevails. And with that, we are adjourned.